Haemothorax is the accumulation of blood within the pleural space and is a frequent manifestation of thoracic injury. A massive hemothorax is defined as blood drainage exceeding 1,500 ml after closed thoracostomy or continuous bleeding of at least 200 ml per hour for 4 consecutive hours. Now, let's go to the pathophysiology of the massive hemothorax. Massive hemothorax occurs when traumatic injury lead to significant bleeding into the pleural space. As blood accumulates in the pleural cavity, intrathoracic pressure rise, which can compress critical structures such as vena cava, reducing venous rhythm and decreasing cardiac output. This may precipitate hypovolemic shock. At the same time, the compressive effect on the lung limit their expansion, causing the alveolar collapse, a ventilation perfusion mismatch, and intrapulmonary shunting of all impaired oxygenation and lead to hypoxia. The clinical severity depends on the rate and volume of the bleeding and the patient cardiopulmonary reserve. Rapid, massive bleeding can lead to the quick decomposition, whereas slow bleeding may initially be tolerated, but can actually overwhelm the compensatory mechanism, resulting in respiratory failure and hemodynamic instability. So, what is the causes of the massive hemothorax? The most common are traumatic injuries, especially blunt trauma with rib fractures, where sharp bone edge tear the intercostal or mammary arteries. Penetrating trauma such as stab or gunshot may also lacerate lung tissue, major thoracic vessel, or the heart. In rare cases, spontaneous massive hemothorax may occur due to conditions like rupture, muscular malformation, malignancy, or necrotizing infection. Regardless of the cause, the result is significant intrathoracic bleeding that compromises ventilation and circulation.
On inspection, there is asymmetrical chest movement with a noticeable reduced expansion on the affected side. The neck vein appears flat, indicating hypovolemia. During palpation, there is tenderness over the affected chest wall. On the trachea may be shifted away from the affected due to mediastinal shift because of massive bleeding. On the percussion, the affected site produces a dull sound, suggesting the presence of blood in the pleural cavity. During auscultation, the breath sound on the affected side are decreased or absent because the accumulating blood compressed the lung. These findings are characteristic sign of a massive hemothorax. The symptoms of massive hemothorax commonly include rapid swallow breathing and severe dyspnea, as the patient struggles to maintain adequate ventilation. Pleuritic chest pain is often reported, described as a sharp pain that worsens with a deep breath. Because of significant blood loss, the patient may experience a feeling of faintness accompanied by the pale, cool, and clammy sensation of the skin, which reflect hypovolemic shock. Palpation may also be noted as the heart beat rapidly in the attempt to compensate. In addition, patients frequently show restlessness and anxiety, sometimes progressing to a pronounced sense of impending doom, which is commonly associated with the severe respiratory distress and the shock. The main investigation for the massive hemothorax starts with the chest X-ray, which is typically show a large opacity, collapsed lung, blunting of the costophoretic angle, and possibly a mediastinal shift in the severe cases. A fast ultrasound is a rapid bedside tool that detects fluid or blood in the pleural space, especially useful in the trauma or unstable patient. A CT scan of the chest provides detailed information by confirming the volume of the hemothorax, identifying the source of bleeding, and detecting associated injury such as rib fracture or lung laceration. Chest tube output or diagnostic pleural aspiration also help confirm the diagnosis, where immediate drainage of more than 1.5 liter of ongoing bleeding over 200 ml per hour indicated as a massive hemothorax. Laboratory test support assessment. Full blood count may show low hemoglobin, blood grouping, and cross-matching. Prepare for transfusion. Coagulation profile check for bleeding tendency, and ABG often show hypoxia. Continuous monitoring of vital signs including hypotension, tachycardia, and low oxygen saturation help evaluate the severity of shock and guide urgent management. The treatment of haemathorax begins with the chest tube drainage and the use of antibiotic for 24 hours. After drainage, patients are classified as unstable or stable based on the amount of blood drained. For unstable patients, defined as those with a drainage of greater than or equal to 1,500 mm in 24 hours or greater than or equal to 200 mm per hour, for several hours surgery is required. If the patient is hemodynamically stable, video-assisted thoracoscopic surgery (VATS) is performed. If hemodynamically unstable, thoracotomy is needed immediately. For stable patient with drainage less than 1,500 mm in 24 hours or less than 200 mm per hour, a CT scan is performed. If the CT scan shows loculation or clot, intrapleural fibrinolytic therapy (IPFT) is used. If the condition resolves, no further surgery is necessary. However, if loculation or clot persists, especially when the volume approaches with 500 mm or 1/3 of the thorax, VATS or thoracotomy is indicated. If the CT scan shows no loculation or clot, condition can be managed conservatively after drainage. This structured approach ensures proper drainage, control of bleeding, and prevention of complications.
The objective of chest tube insertion procedure. First, restore normal negative intrapleural pressure and remove abnormal air or fluid to drain air, which is pneumothorax, blood, haemathorax, pus and PMR, or pleural fluid, which is pleural effusion from the pleural cavity. Second, re-expand the collapsed lung by removing trapped air or fluid, allows the lung to fully expand and improve breathing. The third one, restore normal negative intrapleural pressure, helps the lungs work normally by recreating the correct pressure inside the chest. Fourth, improve ventilation and oxygenation by expanding the lung, gas exchange become more effective and better oxygen level. The last one is prevent complications such as dangerous tension, pneumothorax, respiratory failure, or infection spreading. The definition: chest tube, also known as a thoracostomy tube, is a flexible plastic tube that is inserted through the chest wall into the pleural space. Its primary purpose is to drain abnormal collections from this space, including air, blood, fluid, pus, and lymphatic fluid. Next is etiology, the indication or causes for insertion. First is pneumothorax, a collapsed lung, either spontaneous or from trauma, requiring evacuation of air. Second is haemathorax, accumulation of blood in the pleural space, typically after chest trauma. The third one is pleural effusion, a large symptomatic or malignant build-up of fluid that needs to be drained. The fourth one, MPMR or chylothorax, to drain infected fluid, which is pus or lymphatic fluid from the pleural space. The fifth one is post-operative, prophylactically placed after major cardiothoracic surgery to drain air and fluid. Pathophysiology. The pleural space between the lung and chest wall normally maintains a negative pressure. Its negative vacuum is what keeps the lung expanded and stuck to the chest wall. When air or fluid enters this space, the negative pressure is lost and the lung's elastic recoil causes it to collapse, leading to respiratory distress. The solution for this problem is the chest tube acts as one-way valve. It is connected to a drainage system that removes the air or fluid and, most importantly, restores the negative pressure, allowing the lung to reinflate.
Next, for sign and symptom, which is of underlying condition, the first one is a chest pain, which is a sudden, sharp and purity, worse with a deep breath. And the next one is a shortness of breath, which is difficult breathing, dyspnea, and rapid breathing, which is tachypnea. The third one is a vital signs changes, which is a low oxygen saturation, which is hypoxia, and rapid heart rate, tachycardia. And the last one is a breath sound, which is a decreased or completely absent breath sounds on the affected sides. Next, for investigation, which is a confirming the needs, which is a diagnostic. So before insertion, the conditions must be diagnosed and the insertion sites plans. First one is a chest X-ray, CSR. The most common and standards to the clearly show air, a dark space, and or fluids, a white out in the pleural space. Next one is ultrasound, focus, increasingly used, especially in trauma, EFFUS exam, and is a fast portable and can guide insertion in a real time. The last one is a CT scan we use to provide the most detailed image used for complex cases such as loculated wall-off or effusion or edema. Okay, for treatment, we have tract management. Okay, the first one is before the procedure, which is the local anesthesia. We use a lidocaine 1 to 2%, which is 10 to 20 ml. Maximum dose for 3 mg per kilogram without adrenaline and 7 mg per kilogram with adrenaline. Second one is systemic analgesia or sedation with immediate, if needed, fentanyl 25 to 100 IV or morphine 22 to 5 mg IV. And the second one is midazolam 1 to 2 mg IV for mild sedation. So the second one is during the procedure, we give the additional local anesthetic if necessary, and the last one we give a we have to monitor vital signs and oxygen if sedation is used. And the last one is after the procedure, which is we want to pain the control, we give a paracetamol, which is acetaminophen 1 gram PO or IV every 6 hours, and N6 ibuprofen 40 mg PO every 8 hours. And the last one is opioid, including the morphine or oxycodones if pain is severe. And the last one is antibiotic prophylaxis, which is a cefazolin 1 to 2 gram IV for trauma cases or when sepsis is uncertain. So for surgery management, we have the preparation, which is position patient semi-recumbent, so arm of the affected side raised above the head. So the anesthesia, which is we use a local infiltration with 1% in lidocaine to skin, subcutaneous tissue and pleura, and then monitoring the pulse oximetry, ECG and blood pressure. The equipment, which is the sterile chest tube 20 to 36 freaky depending on indications, and scalpel, artery forceps, suture, 0, underwater seal, drainage system, sterile grip and glove. So the next one is safe of insertion, which is the anterior border of latissimus dorsi, lateral border of pectoralis major, and the line above the nipple, which is a 5 intercostal space, apex below the axilla. And the last one is a procedure step, which is the first one is aseptic technique, clean and wrap the area, and then the second one is local anesthesia, infiltrate the lidocaine down to the pleura, and the third one is incision 2 to 3 cm horizontal cut along the upper border of the rib, blunt dissections, use an artery forceps through the intercostal muscle until pleura is figure sweep, insert the figure to confirm pleural entry and exclude the additions. The sixth one is insert the chest tube, which is we have two, which is direct anterior superior for air, which is a pneumothorax. Second one is direct posterior inferiorly for fluid or bloods. And the seventh one we use to connect the tube to underwater seal drainage system. And the eighth one is secure the tube with sutures and apply the occlusive dressing. So the last one is confirm the replacement by observing fluid movement and performing a chest X-ray.
The definition of pleural effusion is the abnormal build-up of fluid in the pleural space, the thin area between the lungs and the chest wall. This extra fluid limits the lung expansion and leads to the breathlessness. So the important fact is normally the pleural space contains only 10 to 20 ml of fluid. And pleural effusion is a sign of an underlying condition, not a disease. It can produce tony dullness and percussions and reduce breath sound. And thoracocentesis helps confirm the cause and relief symptoms. Pathophysiology, pleural effusion develops when the balance between fluid production and absorption is disrupted. This can happen due to increased hydrostatic pressure, reduced oncotic pressure, increased capillary permeability from infection or inflammation, or blood lymphatic drainage. The accumulated fluid compresses the lung and reduces the causes. Transudative effusions commonly occur due to the heart failure, liver cirrhosis, or nephrotic syndrome. Exudative effusions result from pneumonia, tuberculosis, malignancy, or pulmonary embolism. So, to summarize, pleural effusion is a sign of underlying disorder, and identifying its cause is essential for proper management.
When doing physical exam signs, it will show decrease in bass sound, stonical percussion, reduced chest expansion, reduced or absent theta vocal fremitus, reduced or absent theta vocal resonance, diminished or absent bass sound, and pleural rub. When patient came, they will complain and give symptoms like chest pain, autopnea, dyspnea. Investigation for pleural effusion, we can do some tests to identify fluid in lung, chest X-ray, CT scan, ultrasound, thoracentesis, biopsy, and thoracic movements. Firstly, to remove excess fluid, we do thoracentesis where needle inserted into pleural space. Next, the medication, give antibiotics if there is infection such as pneumonia. Anti-inflammatory drugs, diuretics where body eliminates excess fluid by increased urination and bronchodilation such as COPD cases. Lastly, by surgery, pleurodesis and pleurectomy where it is preventing recurrent effusion.